I'm Susan. I'm one of the family therapists on our inpatient psychiatric unit. So Sarah and I work very closely on a daily basis, and this is a topic that we feel really passionately about because we work with a lot of adolescents and children who struggle with depression. And so we hope this presentation is helpful for you. We encourage you guys to ask questions if you're comfortable as we go along, and we'll go ahead and get started.
And just a feel for who's in the audience this evening. Do we have parents of youth here? Show of hands. Okay. Educators, people working with youth. Okay, just a little blend. And we'd like to keep it as informal as possible with the time that we have, so feel free to raise your hand or ask a question as needed. And I'll use the mic when I speak it.
So we just had to start with a little disclaimer just to say that the handouts in the presentation are for informational purposes only and are not intended to be substituted for professional medical advice. We hope to kind of shed some light on depression, maybe give you a few ideas of how to manage it within our children and adolescents a little bit differently or better. But we always encourage you guys to seek additional support as needed. And we'll give a few resources as we go along as well for places where you might be able to seek support if that's what you're looking for.
All right, so I know you all have PowerPoints as well, so I won't read to you, but what we'll do is we'll start with the facts as far as depression and youth. So just a few statistics here, fairly recent statistics. 11% of all adolescents, so children and youth under the age of 18, 19, will be diagnosed with depression symptoms, or some form of a diagnosis by age 18. Looking at more specifically childhood, boys and girls are affected equally as far as rates of depression go. And then in adolescence, girls are twice as likely to experience depression. Why that is, people have different theories. Some people believe that girls may be more predisposed biologically and related to psychosocial factors. Others have suggested that diagnoses are more difficult to identify in boys. And we'll talk a little bit about gender differences as we move on throughout the presentation. Half of those who are diagnosed with depression in youth are diagnosed, will have a second episode, so what we call a recurrent episode within 7 years. The risk of experiencing depression symptoms increases as a child ages, and then episodes of depression in children last 6 to 9 months on average, but in some children they may last for years, and we'll talk a little bit about how that changes over time and again the differences.
So we wanted to talk a little bit about comorbidity, and what that basically means is there are disorders that kind of co-occur or go hand in hand with depression. There are some kids who may be at a little bit higher risk for depression, and we just wanted to look at that. I think it's important to keep kind of a mental note of that, to say if you struggle with this, it's not an absolute that you will also have depression, but it's more likely that you might develop symptoms of depression. So those at higher risk include kids who have previous diagnoses of ADHD, of conduct or oppositional defiant disorders, and those, for people who maybe are not as familiar with conduct or oppositional defiant disorders, that's more of a behavioral disorder, struggling to follow the rules, struggling to accept limits, struggling to kind of follow the directions of teachers or parents or those within authority. Those who have learning disorders that have been diagnosed within school, anything from dyslexia to nonverbal learning disorders or math disorders, things like that. And then those with anxiety disorders. A lot of times we hear from our youth that when they have anxiety, they have depression, and they kind of go hand in hand and affect each other. We talk a little bit about why maybe kids might develop depression if they also have one of these disorders. A lot of times kids will tell us that their self-esteem is so affected by having a learning disability. When they struggle in school and can't kind of keep up with where their peers may be at, or when they want so badly to pay attention and they just can't, despite, maybe being medicated for ADHD. A lot of times that leads to kids getting really down on themselves and trying to figure out, well, why am I different? What's going on here? Why can't I be alongside my peers? A lot of times that's where we see symptoms of depression kind of develop. I think a lot of times kids also get really focused on having some of these previous diagnoses and feeling like they're never going to go away. So if I have ADHD, I'm going to have that for the rest of my life, and it's going to be a constant life struggle. That can often lead to symptoms of depression because it kind of feels hopeless for them at times. We know that many of these things are very, very treatable, and kids can absolutely have mastery and management over them. But sometimes in the moment, obviously, kids have a hard time seeing the forest for the trees. There are other risk factors we wanted to talk a little bit about that sometimes we don't put as much emphasis on, but are really important. So other risk factors where we might see symptoms of depression or depression develop are if kids are under considerable stress. Considerable stress has to be, again, the word is considerable. So it can't just be, oh, I have a math test, oh, I have this presentation to give. We see considerable stress as bullying, as maybe problems in the home, stress in the home, maybe parents who are also struggling with a mental illness, maybe there are financial stressors at home. So things that maybe they're losing their home. We want to talk about considerable stressors. Now again, I think it's important to take into account that what might be considerable stress for one person is not for another. So we need to evaluate that in the moment with each child. Again, other risk factors are, excuse me, trauma. And we talk about, physical, sexual, emotional abuse, neglect.
So a lot of you probably have a pretty good understanding of what trauma is. In our line of work, as Susan was alluding to, we talk about neglect, we talk about all forms of abuse, emotional abuse, physical abuse, sexual abuse, relational trauma. So Susan alluded to bullying earlier. We hear it's a hot topic a lot in the news. We often hear about it. But a lot of you who are maybe in schools, you can speak to the relational trauma that can sometimes go with that and the impact that has on one's self-esteem. Environmental factors related to trauma, again, families living in chronic poverty, a lot of moves, homelessness, family conflict, divorce, anything can be viewed as trauma in children and adolescents, depending on how that affects a child. We know that trauma also has quite the impact on children and adolescents because it can actually serve, as we learn more regarding brain research, it can actually change the structure of the brain. So as we look at depression having sort of both genetic, biological, and psychosocial environmental factors, trauma is a very important factor to take into account when we're looking at a youth's history. Significant loss, so as Susan was alluding to, this can be loss of a relationship, loss of a family member. Again, when there's family conflict, divorce, poverty, moves, there's a lot of different ways kids can experience grief and loss. And then additionally, family history. So we know that there is a genetic or hereditary link with parents who may have mental health issues, including depression. And lastly, we've got substance use, which can certainly contribute to symptoms of depression. When you think of different substances that act as depressants, that is naturally depressing one's system. That is often considered also as a comorbidity factor too. Youth who might be struggling with depression might self-medicate. We see that a lot, and vice versa. Moving on, as the title of the presentation suggests, doing so many things at once here, we are differentiating today between normal sadness, sort of more than a case of the blues, right? So all of you who work with adolescents, who are parents to adolescents or youth, or I think it covers everyone who has been a child or adolescent, we know that there is some natural fluctuation of hormones when one is a child or adolescent, and knowing that, that everyone experiences sadness at times. You know, we talk about it all the time, feeling sad occasionally for typical child or adolescent reasons. And for those of you working with youth, you know that these vary from, you know, general disappointments to not doing well in school, peer conflict, life adjustments, family conflict, body image issues. And we all know that these exist on a range, a spectrum of child-adolescent issues. So naturally, the problems then occur when this sadness does not go away, or it begins to interfere with functioning, which we'll talk a little bit about as far as how to define it. Additionally, I think we hear a lot on the inpatient unit when we're working with youth. The term depressed gets thrown around a lot. Who here has worked with a youth who has said, I just feel so depressed? Okay, so a few of you, yeah, show of hands. You know, we are working with acute children and adolescents who often have a diagnosis of depression. I think some of the language we use in everyday can also have an impact on the words that youth use too. So we really work on differentiating between what is normal sadness and feeling down and experiencing some of life's lows versus a more diagnosable condition that bears some more intense intervention or treatment. And we know that kids are affected differently by different stressors. As Susan just mentioned too, you've got different life stressors that may look quite differently in one child's life as opposed to another's. There's been a lot of recent research in resiliency as well, so learning how kids react to differences as they age. All right, moving on. Any questions so far? Yeah, please.
When you talked about how trauma can change, do you say the effects of the forming of the brain or the functioning of the brain?
Yeah, go ahead.
Well, I just like a little clarification or a little bit about that.
Sure. So a little caveat first, or a disclaimer rather, I'm not a medical doctor, I'm not a physician, certainly not a brain scientist, but what we're learning more about trauma-related changing the structure of the brain. So a normal healthy brain in child, you know, as development progresses, we know that those who are exposed to prolonged trauma of some sort, who aren't getting that sort of attunement or care or things like that, that can actually change the structure of the brain. So when adults experience trauma, that might change our functioning at times, but not the actual structure of the brain. And I don't know the actual statistics, but it has something to do with, you know, as far as just like the weight of the brain changes. We're talking a little bit about structure of the brain. We just learned this in a recent class too. So, but there's a lot of great research out there and people who can describe it better.
Thank you.
Yeah, please.
There's a book written that talks about the stress of poverty and how that does change the brain formation of children.
Yes.
And even maternal stress, because the stress hormone created by the mother can affect the unborn child and their brain development.
Yeah, the cortisol levels, and we talk a lot about fight, flight, or freeze response, and the cortisol hormone, the stress hormone that kicks in, and when kids are living in that chronic fear state, you know, that can have a major impact on the structure and the functioning then of the brain. Yeah.
I think a lot of times we hear parents describe it, it's like they go from 0 to 60 really, really quick when it comes in terms of symptoms of like depression, or that sadness comes on really quick, or that anger, which we'll talk a little bit more about if we haven't already in terms of depression. And I think what's important to remember with that stress, like stress of living in poverty, stress of trauma, that we had a professor describe it to us that they're never at 0. So going from 0 to 60 doesn't make much sense. They're always at like 50 and they go to 60. So their stress level never comes down to what maybe like a standard stress level would be. They're always at stress and then they go even further. And so I think it's just something really helpful to remember as we're working with kids who struggle with trauma and depression and those reactions, that the reactions are bigger because they're already so stressed out. So I'm glad you raised that point. Sorry about that. So symptoms of depression in youth, and we'll talk a little bit about, these are common symptoms that we often see, but we'll also talk about kind of the standard symptoms that it takes to diagnose someone with depression. So oftentimes, very frequently, but not always, thoughts or statements of suicide or self-harming behaviors. I think it's really important to note that just because somebody says they're suicidal or they're self-harming doesn't mean they have depression, and vice versa. But very frequently, these things go hand in hand. Frequent sadness, tearfulness, or crying, that is generally more so than what we would say a typical response to something that's been really difficult, like a death in the family or, a struggle at school, bullying. Major changes in eating and or sleeping patterns, and this can be really difficult to identify in some of our teenagers because their sleeping patterns are already kind of wonky. But we want to look for major changes. Sleeping a ton, not sleeping at all, eating a lot, not eating at all. And we want to look at that over a period of time, not just, well, for 2 days he didn't sleep. Well, what else? We always want to look at what else can we attribute that to before we jump to they have depression. Poor concentration or poor school performance, very common when kids are depressed. They lose the ability to concentrate and stay focused in school. Sometimes they forget to turn in assignments. Again, what we want to look at though is that can we attribute this to something else? Can something else be going on? Maybe they have anxiety, maybe there is something, a bullying situation going on at school. So I think with all of this, probably the disclaimer is we want to make sure, we want to rule out that nothing else is going on before we jump to diagnosing depression. Decreased interest in activities, again, it's important to understand, is it you just don't have an interest anymore, or you want to be interested but you can't make yourself do that anymore? Why do you have that decreased interest in activities you used to like? Social isolation or hopelessness, increased irritability, anger, hostility. A lot of times we see this with our little ones, our children, that oftentimes they present as more angry and hostile rather than that like typical sadness we think of with depression. And then attention-seeking behaviors, which I hate this term because our kids hate this term because they think, oh, you're just calling me an attention seeker when I do things that are kind of outside of the ordinary. A lot of times we see this with self-injury. People call it, well, that's very attention-seeking. And I think it's kind of important that we try to reframe this whole idea of attention-seeking, that it is absolutely okay to want attention when you're not feeling well. I want attention when I'm not feeling well. It's important, though, to go about getting that attention in a healthy and positive way rather than hurting yourself. So a lot of times when kids are really depressed, they struggle to find the words to say, I'm feeling really sad and I don't know what to do about it. Or they feel really ashamed to say that. Or I had a young lady today who said, I'm never going to tell my parents that because then they'll get sad and I don't want to see my parents get sad. And so they go about getting their needs met in a different way. So I think it's important to talk to our youth and try to figure out what's a way that you can get the attention you need and deserve without doing something harmful.
Yeah, and I think it's also important to note that a lot of these symptoms, when we're looking at a diagnosis of depression, we want to see across settings if these are occurring. So, if they're occurring just in the home or just in school, we want to get a better gauge or understanding of maybe what's going on in that setting that could be contributing to that, rather, because a lot of times depression symptoms don't just turn off and on in various settings. Don't get me wrong, we work with a lot of youth who can mask their symptoms well and can be quite productive and high achieving, but once you kind of dig through the layers, it's important to know that, oh yeah, there has been some impairment across a lot of different settings. And according to the DSM-5, definitely not going to read all that, So the new DSM, the Diagnostic and Statistical Manual that mental health providers use, clinicians use to make diagnoses or diagnostic impressions, came out in 2013, the newest version, and there weren't too many changes related to the depression criteria. So youth who are deemed to have a depression diagnosis must have at least 5 or more of these symptoms presenting in a 2-week period, and at least one of the symptoms is the decreased mood or loss of interest or pleasure. So just a few of those, again, a lot of the symptoms that Susan already alluded to, decreased interest and pleasure, the weight loss, weight gain, insomnia or hypersomnia, so very little sleep or a lot of sleep. Psychomotor agitation or retardation, so a lot of times with youth who are depressed or adults who are depressed, we'll see psychomotor retardation where everything, movement-wise, our bodies are physically slowed. However, a lot of times with youth, we'll see a bit of agitation too, especially with our younger ones who maybe have more of those irritability and anger symptoms. You just get this sense that they are restless and uncomfortable in their own skin. Fatigue, as Susan mentioned, loss of energy, feelings of worthlessness or excessive or inappropriate guilt. I think we work with a lot of adolescents who have the guilt piece. Some of them, we work with a lot of wonderful youth, and some of them will question why they feel down, as if they don't have a right to feel down. I've got a good family, I'm doing well in school, I've got friends, I don't understand why I feel this way, and now I feel badly about feeling this way. So there's a lot of guilt around that at times as well. Again, sort of struggles with concentration, so I think those of you who are in school settings often see this, or indecisiveness, just that inability to make decisions, whether it's mundane, what am I going to have for lunch, or big future decisions. Recurrent thoughts of death, so if you're working with youth or have a youth who, there seems to be a lot of themes, and we all work with different creative youth, and different themes come out, and journaling, writing, music, things like that, but when they're talking a lot about death, it's important to explore that, where that's coming from. And then of course that these symptoms that they're having are causing some level of distress. Granted, we work with a lot of youth who minimize a little bit and say, oh no, it's no big deal, and then you have to dig a little bit more and understand a little bit about what, maybe what issues that they are struggling with, or what could be better, because once you sort of start to pull at that thread, you'll get a sense of, there are some things that I would like to be different.
So we just wanted to talk very briefly about other diagnoses that are related to depression in youth, and how you might see some of these. These are a lot of these. This first one is newer to our diagnostic manual, called disruptive mood dysregulation disorder. I think a lot of times we see this in our younger children, and it is kind of shown. It's basically when we see kids who have a lot of outbursts or have a lot of anger and have a lot of difficulty managing that anger. And it seems like their mood tends to go between angry or irritable most of the time. The one part of this, though, is that it can't be just in short bursts. It has to be, this has been going on for about a year or more. So it's often difficult to diagnose this, even though with a lot of our younger kids, we could probably say, yeah, for about the past year, they've really been struggling with this. Dysthymia, or persistent depressive disorder, is something where it's just kind of a lower mood for, generally it's about 2 years. The only difference between this and depression is the depressive symptoms are a little bit more severe, and with dysthymia, they may not have thoughts of suicide. So they might continue to think life is worth living, but they just really don't have an interest in anything, and their mood is just very low or slowed most of the time. And then substance-induced depressive disorder is just kind of a disturbance in mood after intoxication or withdrawal from any type of substance. We can probably all say that happens to a lot of people because, alcohol is a depressant, so we often have that initial high and then we feel depressed afterwards. The difference with substance-induced mood disorder or depressive disorder is that that low mood tends to stay after intoxication and after withdrawal, and it just kind of stays in a low mood. We often see this a little bit more with other types of substances other than alcohol. So generally it's not after alcohol intoxication that they develop this low mood that kind of stays there.
So as I alluded to in one of the first slides, we, even among youth who have depression symptoms, we see a lot of differences both between younger children and adolescents as well as across gender. So between children and teens, and again, we work with youth as young as 4 or 5 at any given time. That's on the very young end, and then youth as old as 19 or 20 in the hospital. So naturally, we're seeing a lot of different presenting symptoms that we can often attribute back to depression. So between children and adolescents, we certainly see children who, when you think of where they're at developmentally, exhibit more somatic or what we call physical symptoms or bodily symptoms or complaints rather than verbal expression of emotion. Granted, we do get kids who are articulate and can identify how they're feeling, both with sadness related and also related to thoughts of hurting themselves at times. But generally speaking, we're going to see those symptoms present in a different, more physical manner. So when we think about physical complaints, we think of headaches, stomach aches, boredom, sort of this restlessness or listlessness. Children also, as Susan alluded to, are way more likely to exhibit anger and irritability symptoms. So when we were talking about the disruptive mood dysregulation disorder, these look more like behavioral outbursts. And it's careful to not diagnose that child simply with a behavioral disorder because a lot of times there's an underlying mood disorder or condition there. And then adolescents simply are more likely to exhibit simply put, a lot more angst. A lot of times they're able to identify to a degree how their sadness, how that low mood is affecting them. They can often verbalize it. And again, developmentally, kids are at very different places despite their chronological age. So we do often see adolescents who have more physical or somatic complaints as well. And then between males and females, this is just a gross generalization. Males are certainly more likely to exhibit anger and irritability and what we would consider outward manifestations of depression, whereas historically females have been more likely to turn inward and exhibit sadness. And these are generalizations and certainly don't do individual differences any justice, and that's important to account for because a lot of times we'll see that certainly females can act behaviorally, outwardly, and then certainly males can turn in and not identify their feelings or hide their sadness as well.
So we just wanted to talk briefly about the effects of untreated or unaddressed depression, and I think it's really an important conversation if we're noticing this in our youth to help them understand, look, here are some of the things that if we don't do something about this now, that could happen. Also important for our parents and our providers to know that if we don't try to address these things with our kids, obviously things can get much worse. So worsening of symptoms, oftentimes we see in an example of school. So school performance starts to go down the hill, and then we start to see school refusal, and then we have kids who have been at home for 3 months not going to school because of their struggling with symptoms of depression. So we obviously don't want it to get to that point. We want to try to address it right when school performance is starting to be affected. Again, poor school performance, struggling to keep up grades that they previously had, struggling to pass classes, struggling to graduate, low self-esteem. Again, oftentimes we hear this going hand in hand. When I have these depressive symptoms, I feel terrible about myself. I feel guilty. I feel worthless. I feel hopeless. I feel like I can't do anything. And that really affects how we see ourselves. Self-medication with substances, we get this all the time. We have kids who come into the hospital who have depressive symptoms who are also using alcohol. I would say alcohol and marijuana are probably the top two that we hear kids say they self-medicate with. And, you know, I think it's one of those things that I once had a doctor that I worked with who said, look, if you are going to school, getting straight A's, everything's great with your family, you're doing everything you need to do, you're working, everything's on track, and you use a little bit of pot, I don't know that I have a huge problem with that. But that never happens. That's the hard thing. Kids will often say to us, you know, it's not a big deal that I'm using this pot. It makes me feel better. Well, it is a big deal because all these other areas of your life are affected right now. Maybe not directly because of the pot, but it's not helping you. So I think we really want to try to address that and help them understand, sure, it might make you feel better in the moment, but what are other ways that we can get that feeling? Because you deserve to feel better. You deserve to have those moments where you don't have to worry about your symptoms or worry about how am I just going to get through the next day. So I think it's kind of it seems counterintuitive to validate, yeah, I can understand why you would use drugs or use alcohol. Obviously we don't want to promote that with our youth, but I think we want to validate the idea that I understand there are moments where you feel better and you would want to keep that. Now let's figure out another way to do it other than using substances. Other effects, so hospitalization can be very common, and I think we also need to be realistic with hospitals that many times with kids who really suffer from severe depression, it can be multiple hospitalizations. It can take a few times for kids to really find either the medication that works best for them or the therapy that works best for them or to work through the things that they need to work through. And helping kids see that just because we're hospitalized multiple times, it doesn't mean we failed the first time. It just means we need another tune-up is kind of how I describe it to kids. And then suicide, obviously.
So we would be remiss if we didn't discuss suicide and self-harm in youth when we're talking about depression. We know that the number one cause of suicide is untreated mental illness, specifically depression. So some statistics that I always think are shocking. Nationally, one life is lost to suicide every 15.8 minutes. Overall, it's the 11th leading cause of death. And then the third, it's the third leading cause of death among youth ages 15 to 19. And I think the first two causes would be accidents and homicide. And then we also need to talk a little bit about self-harm because that could also be a whole other presentation. So self-harm, self-injurious behavior, for those of you who work with youth or have youth, you're probably familiar with this topic. I think it's becoming more known and discussed. And these are behaviors that a person engages in that bring about varied levels of pain or harm, or I guess I would say pleasure as well. There's some additional research about the release of opioids and how that happens when someone engages in self-harm. But the goal is the relief of mental discomfort. So for a lot of us, it's really hard to wrap our heads around self-harm and how one could engage in self-harm. And we talk a lot about it on the unit as kids are often using self-harm as a coping skill. So just like substance use, we don't want to promote that, but they're using it as a tool. It's maladaptive, it's not serving them that well, but a lot of times kids who are actually engaging in self-harm don't have a direct link or desire to hurt themselves in other ways or complete suicide. We get a lot of kids who are using self-harm to essentially avoid acting upon suicide. They essentially want to feel less crummy or different, and self-harm brings that to them. Some kids will even say it's addictive as well. So our work is, like Susan alluded to with substance use, is identifying those triggers, getting to the root of what's causing those symptoms, what self-harm is providing for them, and other outlets or coping skills that they can use to release that, and again, to really regulate a little bit better. A lot of kids who engage in self-harm, they are working on regulating their emotions and working on interpersonal skills. We'll talk a little bit about treatments in a little bit, but there's a lot of really skill-based treatments that focus on self-harming symptoms.
I wanted to just make one more comment about self-harm and how we try to talk about it with our youth. There are many times where I think our youth want a really big reaction to self-harming behaviors, again, because they want somebody to notice, hey, I'm not feeling good. And I think that's really important. What I always try to talk about with the kids that I work with is, I care very much that you're self-harming. However, I care more about the reason why you're doing it. So let's talk about what's behind the self-harm. That your self-harm doesn't, this sounds terrible, but it doesn't excite me all that much. What would excite me more is if we can talk a little bit about why you feel the need to do that and what it's providing for you. So I think if we can, again, try to look at, that's just the outward symptoms that we're seeing. We need to really dig deeper. I often use the iceberg metaphor with kids. We see the tip of the iceberg. I see your arms. I see you're really struggling. Let's talk about what's below the water and why you might be doing that and why you might be returning to that, why it's working for you. Because again, like Sarah said, for many kids, it works wonders for them. We just want to find something that works a little bit better. So we want to talk about the first steps in treating depression. And I think there are many, I guess we could say there are probably many first steps that you could take, but this is kind of what we are looking at. So identifying the stressors or symptoms that need to be addressed. There are probably many symptoms that need to be addressed, and it's hard to know, well, where do we start first? Do we start with the school refusal first? Do we start with the self-harm first? I think what's important is to ask the question to our children and our youth is, what is the most distressing to you? Is the thoughts of suicide most distressing to you, or is the school refusal most distressing to you? So figuring out where they want to start sometimes helps to get their buy-in into the wellness process. I think that will also inform or tell you where we need to start with what level of care. Because if we hear that they are suicidal and have a plan and are going to act on that plan, then clearly they need to be evaluated in the ER or they need to be in a hospital. I always try to remind kids, because I think a lot of times they say, well, I'm not going to tell you that I'm suicidal because then you'll put me in the hospital, and I don't want to be in the hospital. So I always try to let them know that there are plenty of people who struggle with depression, who have suicidal thoughts, and who are not in the hospital because they're able to manage them. So I think it's really important to help our kids understand that just because you have suicidal thoughts, just because you're self-harming, doesn't automatically mean a trip to the hospital and a 10-day stay there. It means we need to talk a little bit more about it, about where those thoughts are coming from and if you're able to manage them. Now, if you tell me I can't manage them, I'm going to act on them, clearly we need to be in the hospital. But again, if they say, I have these thoughts, but I think if we talk a little bit about it, and if we think about what are we going to do to address it, I can be okay, then maybe we need to look into seeing our therapist a little bit more or going to talk to our school social worker. Another thing that, and I think all of these kind of happen sometimes at the same time, are obtaining collateral information or collaborative information from others. So if you're noticing your child is really struggling, asking school or their church youth group or their karate class or their soccer team or their peers, hey, how do you notice that Jimmy's doing? Because when I see him at home, I get a little bit worried. Do you see that too? Again, it's just important to see, is this happening across all walks of Jimmy's life, or is it just at school that he's really struggling? Then we would say, well, let's figure out what's happening in school that Jimmy might be really struggling there. Kids will often say, don't invade my privacy, don't talk to my friends. And I always try to respond with that I don't need to invade your privacy unless I start to get really worried and I see that something's going wrong. then I might just ask your friends what's happening because I care about you and I love you and I don't want something bad to happen. I think a lot of times when we talk with parents, it can be very difficult to remain calm in these conversations with our youth. And so the one thing I try to work with parents on is staying calm during these conversations, as difficult as they can be. It's really hard to ask your child if they're suicidal. But if they notice that you're reacting in a really big way, it's going to be really hard for them to remain calm and present in the conversation too. One of the other steps that we always try to do is get a medical exam, because there are plenty of medical issues that can contribute to low mood symptoms. We have found a severe depletion of vitamin D in our children because they are staying inside playing video games all day long.
They live in Minnesota.
And they live in Minnesota. I won't blame it all on video games. But so is checking vitamin D levels, also checking thyroid levels to see if they're hypothyroid. That can also severely alter mood. So we always want to check those things first.
All right, so there's hope though. That's the beautiful thing about talking about depression in youth. By virtue of working with any youth, there's a lot of hope. And like we talked a little bit about earlier, is a lot of resilience as well. I mean, I always tell families and kids, by virtue of getting past childhood and adolescence, some of these hard symptoms will go away, basically. Not to minimize a clinical diagnosis of depression, of course, but the environmental stressors certainly will hopefully diminish with time. And what Susan and I do is we have a lot of understanding of treatment approaches. So obviously on an inpatient unit, we're working with a little higher acuity of kids with presenting symptoms of depression. And there are a lot of different treatment approaches that we do on the inpatient unit, as well as in outpatient therapy and day programs as well. So beginning with what we call psychosocial treatments. So these are most commonly known as therapeutic interventions. We refer kids often to a lot of different forms and levels of care related to therapy. So you've got individual therapy, where a youth is working one-on-one with an individual therapist who's sometimes trained in a certain modality. With younger kids, there are play therapists out there as well that are just wonderful as far as getting kids to engage in a playful manner. There are group therapy options as well as family therapy options. I think that's a really important key to remember in working with youth, is that when they leave the hospital or when they leave your school or your care, they are going home to a family system, and it's really important to work with that family system as well to increase understanding and knowledge of mental health, as well as to understand how everyone has a dynamic and plays off one another in their communication, and to better equip families to communicate about those symptoms. Two types of more evidence-based approaches to treating depression in youth are cognitive behavioral therapy. So those words, cognitive meaning thinking, thoughts, behaviors meaning behaviors, actions, and how those tie together. So this is a lot of the education we do on the inpatient unit with our youth, as far as getting them to look at some of these thought patterns they get into that help to contribute to those depression symptoms, and how that then affects their behaviors as well. And then DBT, this is sort of under the umbrella of cognitive behavioral therapy. So when I was discussing self-harm earlier, this is a modality that is really skills-based. So you'll find, as you all are familiar with youth, some kids don't just want to go and talk to a therapist. Sitting in a couch, looking at the clock, when is this over? Are we done yet with therapy? Am I better? But DBT is a skills-based modality. And so it's done individually, with groups, as well as with families. And it's focused really on these hardcore skills that I think any adolescent or child could benefit from, related to emotional regulation, distress tolerance, and interpersonal relationships and effectiveness. And that has shown to be quite effective especially with youth who have histories of self-harm. Psychoeducation, so this is a lot of what we do on the inpatient unit, is providing education about how our brains work, how our bodies work, what these symptoms are, how, especially with our younger kids, where you might feel these symptoms in your body, and then a lot of work around coping skills and education and accessing support. We do all that with families as well. Medications, we'd be remiss in talking about treatments for depression without discussing medications. Meds, we're obviously strong proponents of medication approaches, especially on the inpatient unit, just due to the acuity of the symptoms that we see. And medications can often elevate kids' mood to a point where they can really start to engage in therapy. We often have a dual approach. So a lot of studies have suggested that a combination treatment is safest and most effective. So medication approaches as well as a therapeutic approach. And of course, the disclaimer with medications is that they should always be monitored very closely by a primary care doctor or a psychiatrist when starting and changing. Yeah. And then of course, healthy lifestyle choices. So we do a lot of work around this as well. I don't know, who here has a cell phone? Okay, silly question. Who here sleeps next to their cell phone, or is it within arm's reach? Anyone? Okay. Oh, come on. Yeah. So we as adults do that, and we know what impact that can have on us as we're drifting off to sleep and get that text, or we think of that one to-do thing that we should, I'll just email myself it and then go to bed. So we know that happens in adolescence as well. So whether that's phones or video games or things like that. So we often do a lot of education about shutting down, powering off, getting into a sleep schedule, because we know that adolescents often need as much sleep, I think, as a newborn, is my understanding. So the importance of that. And because they have to go to school Monday through Friday, it should be during certain hours that we want them getting that sleep. And then, of course, diet and exercise. So we talk a lot about, we're doing a lot more at Prairie Care related to integrated and holistic care. So food choices, the importance of exercise, again, just getting up and moving. Not that, doing yoga and joining a running club is going to cure your depression, but we know that it can have some positive benefits in releasing some of those natural feel-good hormones. And as I alluded to with both meds and therapy, the importance of any treatment approach in working with a youth with depression symptoms is sort of a whole child or whole person picture. So again, looking at all those different facets of that child's life and providing different support in all those areas.
And then we just wanted to talk a little bit about what families, and I can relate this probably to providers as well, what we can do to help our youth and children who have symptoms of depression. One of the biggest things that we get from our youth on the unit is communication. And either the youth isn't communicating with the parent or the parent isn't communicating with the youth. Very often youth don't have the language to, or little ones especially, don't have the language to describe what they're feeling. And so what we try to do is, aside from giving them language, we try to help parents and providers help them find the language to figure out and name what they're feeling. I think that can be a really difficult thing when we may not even know how to approach it ourselves. But what we always, again, I talked about this a little bit before, we try to approach it with a very kind of neutral, keeping very calm, and trying not to, blow it out of proportion, even when inside we as parents are like, oh my gosh, what is happening? And we're freaking out. Again, that's probably not going to lead to the best conversation with your child. So trying to stay as calm as possible as you're going through this conversation with them. The two big things that I always get from our kids is, I need my parents to listen, and I need them not to judge me when they talk. It's really difficult to know how to do both of those things, because sometimes it feels like we can't do anything right. So one thing with listening, I have broken that down many times with kids. So how do you know that your mom is listening to you? Because mom will say, I'm listening, I'm sitting here with you. But the kid says, well, it doesn't feel like you're really listening to me. So we talk about, so what does listening look like? Does listening mean I'm just sitting there staring at you? Can I nod my head? Can I offer my feedback? Can I hold your hand as you're talking? I've gotten very specific with families on saying, this is what listening looks like to Susie. So she knows you're listening if you do these things. Because again, a lot of times what we think as a parent that we should be doing is not what is helpful for our child. So it's really important to talk about what does listening look like, even though that seems like a silly conversation. And then talking without judgment. I think it's really important to try to allow them to explain what they're thinking, and maybe trying to give them some language along the way, but not giving them answers or not giving them, I think you're feeling this. Sometimes kids will feel like that's judgment or that you aren't listening to them and just coming up with your own assumptions about how they're feeling. One thing that we often get from kids is that they can't stand it when they hear their parents say, I understand. And they can't stand it when I say I understand, because I don't understand. I have no idea what it's like for you. I can imagine what it's like for you. I can imagine that it's very difficult and sad or hard or exhausting, but I will never understand what it is like for you. Sometimes just saying that is really, really helpful. Sometimes then they feel like you get it. So I often try to replace the I understand, even if maybe you've experienced depression yourself and you know what depression feels like. Again, it's never the same for each person, to say, I can imagine that's really difficult for you. Or even just saying like, wow, that sounds really, really hard. I'm so sorry. Sometimes we want to say more, and sometimes saying less is actually the better thing to do. The other thing I want to say is it's okay to say, I don't know, or I'm not quite sure what to do in this situation. I think there are many times I have parents in my office that say, I'm a fixer, and I just want to fix it, and it becomes very frustrating for them when they don't know how to fix it. And it's okay to say that. It's okay to say, you know what, Tim, I'm really sorry. I don't know what to do in this situation. I feel really sad. And to name your own feelings, but then talk about, but you know what, we're gonna go talk to this person. We're gonna go do this and try to find some answers for you. I think it's sometimes really helpful to hear from your parent that, maybe you don't have all the answers, but you're gonna help them find the answer. Providing a lot of validation. We get this very frequently that kids say, I just want somebody to tell me that it's okay to feel what I'm feeling. We've been talking about this a lot lately, that sometimes with the buzzword around our unit is coping tools. Use your coping tools. And kids see coping tools as I'm gonna do some coloring, I'm gonna throw this ball against the wall. Sometimes I think those are great. Sometimes I just think it's a momentary distraction, but it doesn't really address the feeling. And it doesn't help kids to feel their feelings, if that makes any bit of sense. So a lot of times we provide a lot of validation to say it's okay for you to feel sad. It's okay for you to feel angry and frustrated. And it's okay to say as parents, I feel sad for you. I'm sorry this is happening. I think it's a lot of times kids just want to know that what they're feeling is okay and is normal. And a lot of these symptoms that kids experience are very normal. So it's okay to say that. It's okay to say, I know you're sad, and it's okay to feel sad right now. And we need to get you a little bit of help. Paying attention to the warning signs. Kids will often say this, that I was throwing out all these warning signs and nobody picked up on it. And that can be really hard because we're not mind readers as much as kids think we are. So a lot of the warning signs that we try to focus on are, again, those really significant changes. School performance is changing. A big warning sign we often see is like a change in friendship groups. If you were friends with one group 1 minute and then that drastically switched, that might be something to pay attention to. stopping interest again in activities that they used to love. So they were on the soccer team and then they randomly quit. That's something to really pay attention to and try to figure out what's going on there. Setting a really good example that promotes a healthy lifestyle, so that can be really difficult because as adults we get super busy and it's hard to maintain all those areas of our lives that would be that would promote a healthy lifestyle. But the one thing we get a lot of feedback on from our kids is family dinners. I really want to sit down and eat dinner with my family, and it doesn't have to be this huge thing. It can be 30 minutes together, but that is really, really important and a great time to connect with our kids. I think a lot of times with so many activities on the table right now, we forget how important it is to just sit down with our kids and eat dinner together. And honestly, we get that one all the time. Kids think their parents aren't going to be very receptive to it, and many times parents are quite receptive to it. We often get from parents, though, they say, well, I'm willing to do a family dinner, but then I have it and they don't come downstairs for the dinner. And so we just stopped. I think with a lot of these things that we want to change, whether it's changing sleep habits, whether it's changing family connection with family dinners or a Sunday fun day, things like that, we want to make sure we do it over a period of time and not just once. And if it didn't work once, we don't want to throw it out the window. We need to keep trying. So, okay, Jimmy's not going to come down for dinner tonight, but I am going to continue at 5:30 every night. We are going to have dinner. And that's because that's a transition. It's going to take time for somebody to fall into that different pattern and to recognize, oh, we actually are going to have dinner together. Well, that's great. So I think, again, it's really important when we start to make these changes that we're not just doing it once, we're doing it over an extended period of time. I think there was some research that was like it takes like 21 days to form a new habit. And so sometimes it's 21 nights that we have to hold family dinner until somebody might actually come to it. It can feel exhausting, but it's really important.
We don't have to for 21 days on our inpatient unit, but it's amazing how both kids and families alike will talk about the visiting hours. So on the unit we have evening visiting hours, and families are encouraged, of course, to come if they can, and a lot of them will bring food and they'll just sit down and visit. And no one, I mean, it's unnatural in some ways. We don't sit at home and sit across from each other with nothing else going on and visit and catch up. But they start doing that on the inpatient unit, and that can make a big difference. I mean, it's certainly not a cure-all, but it's a good reminder again of where families are at communication-wise, or the things that they really do enjoy talking about. Granted, a lot of kids aren't feeling their best on the inpatient unit, so visits aren't always necessarily sunshine and flowers, but it can be a nice reminder of like, oh yeah, this is kind of what we're lacking. And kids love the McDonald's that their parents inevitably bring them from next door. So.
But we're not saying
No.
McDonald's.
Right.
So.
Speaking of healthy lifestyle choices, yeah.
Speaking of that, I think the other thing that we've noticed a lot, parents getting into exercise and physical activity and bringing their kids along and doing that. We have started a yoga practice on our unit. So during the weekends, kids practice yoga with a teacher, and it is amazing how calming that can be for kids. And so I know many parents practice that. Bringing your kid along with that can be a really great time, not only to connect, but can show, look, I'm going to be physically active, you can do that too. Another great coping strategy that kids often talk about is just going for a walk with my family. And we've again broken that down to, what do you want to do on that walk? Do you want to just walk together and not say anything? Or do you want to talk about what's going on in your day? It's great to give kids that option of, we don't have to talk all the time. You don't need to think that I'm going to therapize you as we're on this walk. We can just walk, and that's okay. And then supporting your child and following their treatment plan and taking their medications. It is amazing how many kids stop their medications, especially the medications for depression. Oftentimes they take 4 to 6 weeks to show their full effectiveness, and kids will stop them after 2 weeks and say, they're not working for me. Well, you didn't give it the fair shot.
Or I feel better.
The other issue is a lot of times kids say, well, I'm feeling so much better, so I'm going to stop it. We would advocate that many times when you start medications, that you stay on them for about a year. And during that time, other than taking medications, you're doing some pretty intensive therapy. And then after a year, if everybody looks around and says, wow, you know, Erin's doing really good, I think we can probably try something different, then would be a great time to try maybe going off of the medications and staying with therapy. So I think sometimes kids start medications and think, I'm gonna have to take this for the rest of my life, and that's daunting. No, that's not always the case, but we wanna make sure everything is going a little bit better until you go off the medications. So again, advocating that they stay on it, that they take it, and sometimes that means administering the medications yourself. Even though we want to put more responsibility on our youth, especially our older youth, sometimes that's just an important thing to do to maintain that medication regimen.